and we have a unique opportunity to move things forward. I would be very disappointed if everything we came to, let's say, the supposed end of the COVID-19 pandemic restrictions, and we just flicked the switch and everything went back to the way it was. I think that would be a huge wasted opportunity. We are doing some really good things that we would never have otherwise been able to do in the same time frame.
From new tech to altered prescribing practices, in this episode we ask, what long-term effects could COVID-19 have on general practice?
So, increased use of remote consulting is a good thing. We're saying, it's better for the environment. It saves time if people aren't traveling to the surgery unnecessarily. Great, let's build on that. We're using video consulting. In my surgery, we've been piloting video consulting for a few months, but we've only had 3 sets of kit, but we've got over 20 doctors. And that's because the NHS just only had the resource to provide 3 sets of kit for us. Now we've just said, well, we can't wait any longer. We're just using our mobile phones and a fix in terms of an app that'll do the job for us. It's not NHS approved, but necessity is being the mother of invention. And I think we'll find more and more things will suddenly become mainstream that we've just used as a temporary measure, but that have turned out to be less sophisticated than what the NHS had envisaged for us, but are perfectly adequate for our needs. And sometimes a quick, safe fix is better than a sophisticated long-term solution.
Yeah, absolutely, particularly as the situation's moving incredibly quickly. And I know I saw recently on the news kind of the number 10 Downing Street using Zoom, in fact, for their cabinet meetings there.
Yeah, fab.
Are there some patients that actually, looking to the future, we're thinking actually we're going to do far more video consultations with them because it's easier, it's more convenient. And some patients where actually the nature of what they're coming in with and the complexity means that actually we're probably not going to move towards that sort of care.
Yeah, absolutely. And I mean, there's no doubt that younger people who are working, people who are, if we say, occasional users of the NHS who frequently only present because they're acutely unwell, want quick access, and the flexibility of video consulting suits them beautifully. And, many of us have been crying out for that in the NHS, but it's just taken a bit of time. Suddenly, we've found solutions, so let's just keep doing it. I have to say there are some people who would like to use remote consulting who actually I don't think it's appropriate for. People who underestimate the significance of their problems, some people with mental health problems who don't want to leave the house, and actually just forcing them to come out and confront some of the challenges may at times be appropriate. Other times it's much more helpful to have any consultation than no consultation. Obviously, there's certain groups where they're really frightened or unfamiliar with technology, and obviously we've always got to be cognizant of them. And I'm always very wary of the digital divide, where the people who haven't got a phone at all, let alone a 4G-enabled smartphone, often those in greatest need of care, are the ones least able to access it when we move to a remote method of consultation. So who's caring for those who are digitally naive or financially divided? So those are all very, very important factors. We always have to have the ability for somebody to pitch up at the surgery because there is no other way of them seeing us or interacting with us. I think we shouldn't underestimate the power of older people to embrace technology. I've been delighted and impressed by when they needed to. People have just stepped up and done it. Sometimes people need a bit of hand-holding, but frequently they find it incredibly empowering to learn to use new technologies. And again, there is this narrative about how we empower people and make things simple. And sometimes simpler solutions will achieve far greater adoption than more sophisticated ones. And I think we need to be mindful of that in the NHS. And this does also tie in with the narrative about people with learning difficulties or particular behavioural problems. And again, simpler solutions are more likely to be successful. So lots of different things. I mean, it is, we are in such a dark, bleak time. It's good to find positive things to pull out of it.
Yeah, and indeed, looking at the work done by Babylon Health in kind of London and expanding out, they've definitely listed certain groups of patients whom their video consultations aren't as appropriate for. You mentioned people with mental health disorders and perhaps learning difficulties. I thought it was interesting as well, just this idea that it's quite a huge burden on somebody to have to judge how important kind of various different symptoms they might have are, because I think more and more people are not coming to GP practices with just one issue. They're coming with lots of different things, and that kind of speaks to this relationship that you have with a patient and the continuity of care that you can actually really kind of unpick that.
That's right, and this is the inherent risk that you carry in remote consulting, is that because when you can't see the whites of people's eyes, or you feel you're not connecting with people in the same way, it's what is being lost, what's being missed, hence sometimes needing to ask more questions and so on. But there are lots of tools at our disposal, and there are triage tools and symptom checkers and so on that will certainly help us in the medium to longer term. There are also, I think, looking to the future, there'll be an awful lot of pre-consultation and measurement and assessments that we'll be getting. Nowadays it's completely normal for patients to provide me with their blood pressure readings and things in advance of a consultation. Just prior to the COVID-19 pandemic, we had installed a nice piece of kit in our reception area where people could be given a token, and then the nice machine would do their blood pressure, their height, their weight, calculate BMI, and so on. And these kind of testing points are going to become more and more popular, and will be, before long, we'll have them built in with ability to check all sorts of biochemical things too.
And especially with time pressure.
Yeah, absolutely. It'll help us use our time more effectively. We'll be better informed, so we can use our time more efficiently.
And speaking of the long-term effects on general practice in particular, we've touched a bit upon this idea that kind of remote consultations could grow, and we could get more adept at using those in general practice. But do you think there's anything else that will be changed almost for the, well, let's start with for the good by this crisis?
Yeah, so I think the more rapid adoption of technology, I think investing in technology, and so I come back to the point I've made already about possibly worrying less about the really fancy whistles and bells stuff and just grabbing stuff that works and using it. I think some of the issues around data protection and how we share data, I think will open up new conversations about data sharing. I think people will suddenly, perhaps trust the NHS more to do what's right for people, but that'll be an interesting one. I think in terms of general practices and working, so the GP triage of cases, I think will become much more normal. It's been very, very variable around the country. So I think and using the multidisciplinary team better. I mean, quite frankly, at the moment, patients are just delighted to get any sort of care from their GP service surgery at the moment, and the sort of complaints we used to get about, are you fobbing me off with somebody other than a doctor? We're getting far less of that. People are much more grateful for the amazing care they're getting from our nursing colleagues, our advanced nurse practitioners, our physios and pharmacists and so on. So I think we will have moved the public forward in terms of their acceptance that the NHS is genuinely trying to do the best for them. And certainly the love that we're feeling for NHS employees is really quite special and unprecedented. In terms of negative things that will come from this, well, of course, I really fear for people with long-term conditions and the management of them. We've spent decades improving long-term disease management, prevention, and monitoring, and suddenly, where everything is being relaxed a bit, and our very tight rules about, annual checks and annual blood tests or 6-monthly monitoring are being relaxed, and it'll take a long time to get that back on track. I really worry about the late presentations of disease. So people have been sitting on a breast lump, or they've been waiting, feeling very peculiar, and suddenly they've got really nasty liver disease that's caused complications by the time they present, because they didn't want to trouble us. We already have cohorts of people who present late because they don't want to make a fuss, and this is only going to amplify that. So yeah, there will be good and there will be harm that comes from this. And of course, the idea, of course, is we minimise the harm and amplify the good.
Yeah, it seems that the easiest things to prioritise at these times are not necessarily the best things to prioritise sometimes.
Indeed, absolutely, and we need people who can take a step back to look at the bigger picture to help us work out what we are prioritising.
And in terms of over-treatment, which I know I read a recent article by Margaret McCartney in The Lancet about it, and she spoke very eloquently about it and said that actually that one good thing that could come out of this is our recognition of some over-treatment practices that are pretty endemic in medicine. Do you think there'll be positive changes here?
I hope so. The over-medicalisation agenda has been growing over the last few years, and Margaret is an absolute star in this field. But there are many others too. So yes, I think it will help, because clinicians will automatically, the first thing we'll stop worrying, we won't be worrying about cholesterol management very much. We'll be focusing on, gosh, what are the serious and urgent things that we've missed, as opposed to the non-urgent things. The difficulty is that patients often self-select, and sometimes it's the patients that make a fuss and say, excuse me, I'm overdue for my review, that may get our attention rather than those who genuinely need it. So, as you say, it's prioritising the easy stuff is not necessarily the right thing. So we're going to have to be very vigilant as we restart normal services and monitoring. And, the monitoring that we have is done with the best possible intent. The drugs we prescribe were usually started with good intent, but can end up in an over-medicalisation approach. And using this as an opening gambit for conversations about reducing medication or reducing reliance on traditional conventional medicine is a good thing.
I guess another thing that some people have talked about is bureaucracy and lots of kind of paperwork and things that are allowing actually GPs to prioritise the things that are important for their patients' care, not necessarily important for political ends and things like that. Do you think there'll be improvements here?
Yes, we've had, we've had a few announcements already where things are being made easier than they've ever been before. So we've got sort of, doctors' appraisals are a classic one. I don't think anybody would disagree that it's important for healthcare professionals to be up to date and to demonstrate that and to be supported in that. But there has been a lot of conversation about the appraisal process and whether it's too bureaucratic, and certainly that's been lightened and extended. I think that's welcome. I think inspections by the Care Quality Commission are being lightened and made proportionate to the times. Now, patients are absolutely needing to have the assurance that the healthcare services, health and social care services they use are safe and well managed. But as we've had CQC around for quite some time, all organisations are working in much more standardised ways than they've ever done before. So if the CQC just focuses on the areas of concern right now, that would be helpful. Because, for example, in a standard general practice, when it's time for a full CQC inspection, every partner in the practice and all the senior staff are taken out of seeing patients and routine duties to service that visit. It's always felt a little bit disproportionate compared to how visits and assessments happen in secondary care, where very few clinicians in a hospital are wrapped up in the CQC assessment process, whereas a lot in general practice are. So things like that will be welcomed. I think there are other things about processes around death certification. I mean, that's always been a very bureaucratic process. Suddenly we're allowed to post death certificates and email things. Hurrah! Things have always had to involve bits of paper being driven around the countryside before. So, that sort of modernisation is happening at pace, which I think is a good thing. So, yeah, it's that thing about some bits will be welcome relief, other bits will be long overdue improvements.
And do you think that we're actually going to get evidence tying this all together that lots of the things that were kind of conducted in a very drawn out process or with a lot more barriers don't necessarily need those barriers? You mentioned kind of posting death certificates or lengthy inspections and appraisals. Is there any evidence for them being actually kind of effective in their current form above kind of less kind of major?
No, there's plenty of evidence of things being effective in their current form, and there's been no pull factors to change. When we talk about change, you sometimes need push factors and pull factors. And whilst there have been lots of attractions in changing, there's been no push to make things happen, whereas suddenly now COVID-19 has given us an almighty shove. So suddenly things are happening very fast, whereas they were moving forward at a snail's pace before. Honestly, just the changes in death certification have been talked about for years and years. I mean, possibly a decade or more. And suddenly they happened within a matter of 2 weeks. That's the push versus the pull. We must grab the good bits out of this while we can.
Yeah, and certainly there are lots of unforeseen ways in which this would benefit general practice.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.
As ever, we'd love to hear what you think. Do leave us a review on Apple Podcasts if you have a moment, and you can also reach us via our website and our social media pages.